Hello, welcome guys to the second part of our series. In this part, we are going to further discuss some important questions related to dialysis which have been asked in the RRB examination previously. So, the first question here is dialysis patients on mechanical ventilation, what will be our primary concern? So, option A says ventilation cause fluid overload, option B says no effect on adequacy, option C says increase PEP improves dialysis. Option D says ventilator settings are unrelated to acid base. So, what will be the answer? So, the answer according to RRB here is given as ventilation causes fluid overload. Positive pressure ventilation, especially high PEP, affects venous return and fluid balance. Fluid status may be carefully managed during dialysis to avoid volume overload or hypertension. But this question has caused several questions in the minds because all everybody in dialysis they know that there is no direct relationship of volume overload with mechanical ventilation, but in critically ill patients on mechanical ventilation and HD, uh, they usually are volume overloaded. So what happens here that when we perform mechanical ventilation on such patients, it alters the blood distribution and perfusion in the patients, which can result in fluid retention indirectly. So that's why this option is most suitable. So now moving to the next question. It says recommended daily protein intake for CAPD patients. Option A is 0.9 gram per kg. Option B is 1.8 to 2.5 gram per kg. Option C is 0.5 gram per kg and option D is 1.2 to 1.3 gram per kg. So this I think will be the easiest. One thing we have to take in mind is that whenever we talk about protein intake in dialysis patients, in CKD patients, we generally follow conservative approach. But while they are on dialysis, and particularly when they are on peritoneal dialysis, there are higher chances of losing protein. So the protein that is recommended in those patients is generally 1.2 to 1.3 gram per kg. Moving to the third question and 13th in this series, it is SLAD is mainly used in what kind of patients? Nephrolithiasis, acute kidney failure in critically ill patients, pediatric patients, or chronic renal failure patients. So basically, where generally we use SLAD, we use them in patients with AKI, critically ill and hemodynamically unstable. So SLAD is a hybrid therapy used in ICU patients who are hemodynamically unstable. It provides slow, gentle dialysis over long hours. Moving to the fourth question, what are the basic building block of protein? So this is particularly a factual question. Many of you have studied it in your class 12th biology. So the answer will be amino acids. Proteins are polymers made by linking amino acids via peptide bonds. These are essential for tissue repair and enzyme functions. Moving to next question, it says which dialysate component regulates blood pH. So out of these four, which component regulates blood pH? So the answer is bicarbonate. Bicarbonate is a dialysate, corrects metabolic acidosis. It diffuses into blood and buffers excessive hydrogen ions. So this is how it regulates the blood pH. Moving next, the question says heparin LOX amount for dialysis catheter is determined by standard dose by weight, fixed 2 ml, 1000 IU each lumen, or volume marked on the catheter. So the amount of heparin that we are going to lock is generally indicated on the catheter. Each lumen has a specific internal volume printed on the catheter. Heparin lock should match that exact volume to avoid systemic anticoagulation. Moving next, the question says kidney conditions in smokers resembles diabetic nephropathy biopsy. So which conditions we normally find in smokers or chain smokers resembling to diabetic nephropathy? So here the answer will be smoking associated nodular glomerulosclerosis. Chronic smoking can produce nodular lesions similar to diabetic nephropathy on biopsy even without diabetes. Moving next, the question is primary purpose of continuous biosignal monitoring during HD. Now, the main function of continuous BP monitoring, heart rate, and other signals, they helps detect arrhythmias. They allow staff to intervene before severe complications occur. There is no particular role of them in enhancing purification. Uh, so that's how they generally help. Moving ahead, horseshoe kidney most commonly fused at on which pole the so horseshoe kidney is a congenital condition mainly found in kids and adults, mainly in kids, where the kidneys are fused together at some point, and that point lies on upper pole, lower pole, or middle pole. This is what the question want to ask. So it is very tricky one. Generally, the kidney is fused together at the lower pole. So most horseshoe kidneys are fused at the lower poles during development. They form a U-shaped kidney across the midline. One thing you also need to know that these kidneys are not functional. Moving next, most common opportunistic infection in HIV patients will be. So this is also a question that have been asked in previous RRB. So the first option is pneumocystitis pneumonia. Option B is E. coli. Option C is bacterial infection, and option D is strep throat. So the answer will be PCP. Is a classic opportunistic infection in immunocompromised HIV patients, especially with the low CD4 count. So hope this video was helpful to you. Make sure to like this. Thank you.